Hello everyone, today we'll be discussing about maxillary sinus and its pathologies. The contents of the topic is classification of various paranasal sinuses, the introduction of maxillary sinus, classification of the diseases associated with maxillary sinuses, clinical features of various diseases, radiological features of various diseases as well as their management. Paranasal sinuses. These sinuses develops as an invagination from nasal fossa into their respective bones. Either it is maxillary, frontal, sphenoid or ethmoid, and they continue to enlarge until skeletal maturity. There are four most common paranasal sinuses. First is maxillary, second is frontal, third is sphenoid and fourth one is ethmoid. Coming to maxillary sinus. Maxillary sinus or antra, it is first one to develop and it is most commonly developed in second month of intrauterine life. It forms by invagination in the lateral wall of nasal fossa in the middle meatus. At birth, it is 8 mm in length in anterior-posterior dimension. With progressive pneumatization of the maxilla, sinus enlarges. Coming to the disease associated with maxillary sinus. First one is intrinsic diseases, which basically originate from the tissues within the sinus. Then coming to second diseases, that is extrinsic diseases, which originate outside the sinus. Coming to the classification of intrinsic diseases of paranasal sinuses. The first one is inflammatory disease, which include mucositis as well as sinusitis. Second one is retention pseudocyst. C is polyps. D is anthrolith. E is mucocele. And F is neoplasms. Coming to the extrinsic diseases of maxillary sinus, which include various inflammatory diseases, various benign odontogenic cysts as well as neoplasms, bony dysplasias, as well as dental structures displaced into the sinus. Now we'll be broadly discussing about intrinsic inflammatory diseases. The first one is mucositis. Most common clinical feature of mucositis is localized thickened mucosa. The normal mucosal lining of the sinus is 1 mm thick. In inflammation, it increases to 10 to 15 times. Coming to the clinical feature, it is an incidental finding and most commonly the patient doesn't show any symptoms. The imaging features of mucositis includes thickened mucosa, which basically appear as a well-defined non-corticated radio-opaque band of increased radio opacity paralleling the bony wall of the sinus. As we can appreciate in this IOPA, thickened sinus mucosa is visible, which is appreciated as a radio-opaque band which parallels the contour of maxillary antral floor as demarcated by black arrows. Coming to the secondary intrinsic diseases, that is sinusitis. Sinusitis is characterized by a generalized inflammatory condition of sinus caused by allergen, bacteria or virus. The inflammatory changes leads to ciliary dysfunction and retention of sinus secretions and sometimes blockage of osteomeatal complex. Now coming to the condition pansinusitis. Pansinusitis is sinusitis affecting all the sinuses. Clinical feature of acute sinusitis is pain. Often it can be a complication of common cold. Nasal congestion accompanied by clear discharge and pain and tenderness or swelling over the involved sinus. The pain, if it is referred to the tooth, leads to percussion tenderness. Coming to the second type of sinusitis, that is chronic sinusitis, which can be a sequelae of acute infection that fails to resolve by 3 months. And chronic sinusitis basically develop with anatomical derangements most commonly due to deviation of the nasal septum because of the presence of concha bullosa, जो कि inhibit करेगा the outflow of the mucus, allergic rhinitis, asthma, cystic fibrosis, as well as due to dental infections. The imaging features of sinusitis is generalized mucosal thickening along the sinus walls along with near complete or complete radio-opacification of the sinus. In contrast with mucositis, there will be a localized thickening of the mucosa, but in sinusitis there will be generalized mucosal thickening along with near complete or complete radio-opacification of the sinus. The management of acute sinusitis is decongestants to reduce mucosal swelling and antibiotics in bacterial sinusitis. For chronic sinusitis, ventilation and drainage is the treatment of the choice. This is the radiograph. It is basically a Waters view which demonstrate complete radio-opacification of left maxillary sinus, and air fluid level is also visible in right maxillary sinus, as you can appreciate by seeing the arrows in black color. This is the CBCT view which shows peripheral bony thickening of left maxillary sinus from chronic sinusitis. Now the third one, intrinsic disease, is retention pseudocyst, which is also called as antral pseudocyst, benign mucus cyst, mucus retention cyst, mesothelial cyst, pseudocyst, interstitial cyst, lymphangiectatic cyst, false cyst or retention cyst of maxillary sinus. Why it occurs? The mechanism behind the occurrence of retention pseudocyst is due to blockage of secretory duct of seromucous gland in the sinus mucosa, which basically results in the pathological accumulation of secretion, results in the swelling of the tissue. The second etiology for the retention pseudocyst is due to cystic degeneration within inflamed thickened sinus lining. Coming to the clinical features, most commonly it occurs in spring or fall. Most commonly it is seasonal variation. It shows signs and symptoms are very rare. Imaging features, in retention pseudocyst you will appreciate a well defined non-corticated smooth dome shape and mostly sessile radio opaque mass. The management as such, there is no treatment. As we can appreciate in this radiograph, a non-corticated dome shaped retention pseudocyst is visible, and the cyst basically shows non-corticated borders indicating that they arise from within the sinus, indicating that they are intrinsic, as you can appreciate by white arrows. In this sectional OPG also we can appreciate non-corticated borders of retention pseudocyst, suggestive of intrinsic etiology. In this CBCT image also we can appreciate dome shaped non-corticated radio opaque masses in both right as well as left maxillary sinus, suggestive of retention pseudocyst. Coming to the fourth type of pathology, intrinsic pathology, is polyps. The polyps are nothing but thickened mucous membrane of sinus which forms the irregular folds called as polyps. The most common clinical feature is displacement and destruction of bone. The imaging features of polyps is that it is always associated with thickened mucous lining, because it is nothing but thickened mucous membrane of sinus which forms the irregular folds. Coming to the next pathology, that is anthrolith. It occurs in maxillary sinus as a result of deposition of mineral salts around a nidus, or could be extrinsic, that is because of mass of stagnant or inpissiciated mucus or cellular debris. Coming to the clinical features, mostly the patient will be asymptomatic, and if they continue to grow, symptoms of sinusitis develops, which are nothing nasal obstruction or facial pain. Coming to the imaging features of anthroliths, these are mostly positioned on the floor of the maxillary sinus as a well-defined radio opacity in some cases, and in some cases you will see alternating layer of radiolucency and radio opacity in the form of laminations. The differential diagnosis is root fragments, but to differentiate it from root fragments we have to check for root anatomical features. The management is the removal by otolaryngologist is advised. As we can see in this OPG, we can appreciate alternating circular radiolucent and radio-opaque pattern of anthrolith on panoramic image superimposed over posterior wall of right maxillary sinus. In this view also we can appreciate the same. Coming to the next pathology, that is mucocele. Mucocele is also known as empyema, pyocele or mucopyocele. It is expanding destructive lesion due to blocked sinus ostium. The entire sinus becomes a pathological cavity. Mucus secretions accumulate and sinus cavity fills, resulting in increase in pressure. It leads to thinning, displacement and destruction of sinus wall. Coming to the clinical features, the mucocele clinical features depends upon the wall which is involved. If the pressure on superior alveolar nerve causes radiating pain, and you will feel or patient will feel the sensation of fullness and the area may swell. If it is extending inferiorly, it will lead to loosening of posterior teeth. If the extension is medially, then the lateral wall of nasal cavity deforms. If it extends into the orbit, it will cause diplopia, that is double vision, and proptosis, that is protrusion of the globe of the eye. Coming to the imaging feature, the shape of the sinus becomes more hydraulic as the mucocele enlarges. Mostly ethmoid and frontal sinus involvement will be there. The differential diagnosis for mucocele will be cyst or neoplasm, but we have to check for the blockage of ostium. As well as the other DD will be large odontogenic cyst. We have to look for any remnants of internal aspect of antrum. The treatment will be surgical with Carvel Luke operation. Coming to the imaging features, this CT image shows mucocele expansion into the nasal fossa as well as into the infratemporal fossa. Coming to the next intrinsic lesion, that is neoplasm. The first one is benign neoplasm, and the most common affecting the maxillary sinus is papilloma and osteoma. Benign neoplasm of paranasal sinuses are very rare. The imaging features are non-specific. Usually involved portion of sinus cavity appear radio-opaque because of the presence of the mass, and there will be displacement of adjacent sinus borders. Coming to the malignant neoplasm, they are exceptionally rare, less than 1% of all the malignancies, and mostly if malignant neoplasm is there involving the maxillary sinus, it will be squamous cell carcinoma in 80 to 90% of the cases. The clinical features are facial swelling, epistaxis, that is bleeding from the nose, dysesthesia, that is unpleasant sensation on touch by damage to peripheral nerves, paresthesia, as well as nasal obstruction. The mean age of the patient having squamous cell carcinoma of maxillary sinus will be 60 years and is more common in men as compared to women. The symptoms also depends upon the involvement, whether which wall is involved. If the medial wall is involved and it is mostly first to get involved or first to get eroded, the symptoms will be nasal symptoms, that is obstruction, discharge, bleeding and pain. If the lesion is on the floor, then the patient will show dental signs, that is the enlargement of the alveolar process, unexplained pain, altered sensation, loose teeth, swelling of the palate as well as ill-fitting denture. If the lateral wall is involved, there will be facial as well as vestibular swelling which becomes apparent. If the involvement of roof is there, then there will be orbital signs, that is diplopia, double vision, proptosis, pain and hyperesthesia over the cheek. If the involvement of posterior wall is there, then there will be invasion of muscles of mastication, trismus, obstruction of eustachian tube, that is stuffy ear, referred pain and hyperesthesia over second and third division of fifth nerve, that is trigeminal nerve. Coming to the imaging features, there will be non-specific and only bony destruction, which is very common in malignant neoplasm, will be appreciated. The management is radiotherapy or surgery, or can be a combination of the two. The prognosis is very poor, as they are well advanced at the time of the diagnosis. As we can appreciate in this CT scan, the squamous cell carcinoma of left maxillary sinus show destruction of posteriolateral wall as well as the medial wall of the sinus. This panoramic image of squamous cell carcinoma show loss of definition of the cortex of the left maxillary sinus, nasal floor as well as the alveolar crest. Now coming to the extrinsic diseases involving the sinus. The first one is inflammatory diseases. In 10% of the cases, these are the extension of dental infections. Dental infections such as periodontal diseases or rarefying or sclerosing ostitis, they basically cause localized ostitis, mucositis type reaction in the adjacent floor of maxillary antrum. Coming to the imaging features, the inflammatory lesion of extrinsic origin present as a homogeneous radio-opaque ribbon-shaped soft tissue that follows the contour of maxillary sinus, same as mucositis. The thickened mucosa is usually centered directly above the inflammatory lesion. That is the main point of difference. As it is because of dental infection, so thickened mucosa is usually centered directly above the inflammatory lesion. Second type of inflammatory lesion is periostitis or periosteal new bone formation. The exudate from the inflammatory lesion strips and elevates the periosteal lining of cortical bone of the floor of the maxillary antrum. Coming to the imaging features, new bone take the form of one or more thin radio-opaque lines, or lines may be thick. So you will see alternative radio-opaque lines. As we can appreciate in this radiograph, the halo-like appearance of bone surrounding the root of maxillary molar is periosteal reaction, and there is displacement of adjacent maxillary sinus floor as well, which is appreciated. Coming to the next extrinsic lesion, that is odontogenic cyst and benign neoplasms. Odontogenic cyst, these are the most common group of extrinsic lesion that encroach on maxillary sinus. Mostly radicular cyst and dentagerous cyst are involved. Cyst and neoplasm as grows, their borders become indistinguishable from the sinus border. As the growth continues, the lesion encroaches on the space of the sinus and displaces its borders. A thin radio-opaque line divides the content of the cyst from the sinus cavity. Coming to the imaging features, cyst or benign neoplasm can have a curved oval or hydraulic shape with corticated borders. The internal structure is homogeneously radio-opaque. In benign neoplasm, there may be fine or coarse internal septations, which leads to multilocular appearance with regions of dystrophic calcification. Odontogenic cyst and neoplasm may displace the floor of maxillary antrum, and they can cause the thinning of peripheral cortex. Coming to the differential diagnosis, the first most common differential diagnosis we have to do for the odontogenic cyst is with retention pseudocyst. Retention pseudocyst, as I told you earlier, it is non-corticated, but odontogenic cysts have a peripheral cortex. If the cyst become infected, the cortex may become sclerotic or lost. In the case of cortex loss, the differentiation may become difficult. Then we have to check for relationship to the neighboring teeth or remaining cyst cortex if it is there or not. Very large cyst or neoplasm, if completely efficacious the sinus, this shows the appearance of sinusitis. We have to check for double cortex as well. Double cortex is the region where both the displaced sinus floor and the unaffected sinus wall meet. As we can appreciate in this image, an odontogenic cyst or neoplasm which develops adjacent to the floor of the sinus. In the first diagram show as the lesion enlarges, it abuts the maxillary sinus floor. Second one shows it ultimately displaces the floor superiorly as it enlarges. The third one shows the border of the cyst and the border of the sinus are now the same line of the bone. And in the B image, we can appreciate as the lesion continues to enlarge, the lesion may encroach on almost all the space of the sinus, leaving a saddle like sinus over it, and we can appreciate double cortex. In this periapical image of small radicular cyst, we can appreciate sclerotic borders along with the involvement of the dental. We can also appreciate in B diagram periapical image of retention pseudocyst. The borders are non-corticated. In this OPG also we can appreciate the corticated periphery of the cyst. In this occlusal radiograph also the peripheral cortex of the cyst is visible. In this PNS view also we can appreciate the peripheral cortex of the cyst along with the impacted tooth which is visible, suggestive of dentigerous cyst. The CT image also shows the displaced floor of the left maxillary sinus. This axial image shows the bowing of the posterior sinus wall and the impacted tooth adjacent to it. This axial CT image of a large radicular cyst, peripheral cortex inside the outer cortex of the sinus, we can appreciate the presence of double cortex. Coming to the next pathology, that is of extrinsic origin, is bony dysplasia, and the most commonly bony dysplasia which are associated with maxillary sinus disorders is peripheral and florid osseous dysplasia. The clinical features are facial asymmetry, nasal obstruction, proptosis, impingement on cranial nerves or sinus obliteration, and it is most commonly present in children as well as young adults. Coming to the imaging features, the posterior maxilla is the most common location for this. Radio opacity with uniform characteristic ground glass appearance on extraoral and orange peel appearance on intraoral views can be appreciated. The differential diagnosis will be Paget's disease, but the difference is it does not obliterate the sinus, and it can be ossifying fibroma which may have a soft tissue capsule and may be more expansile. As we can see in this IOPA, the elevation of maxillary sinus floor by a foci of periapical osseous dysplasia located at the apices of maxillary left first molar. This is a panoramic image, reveals a small region of osseous dysplasia invaginating into inferior aspect of sinus, and we can appreciate the presence of soft tissue capsule. In this OPG, radio opacification of left maxillary sinus is visible and should be appreciated as compared to right maxillary sinus. This axial CT image reveals complete encroachment of the sinus because of bony lesion. Coming to the next pathology, that is dental structures displaced into the sinus. The fractured tooth roots may get displaced into the sinus. The clinical features are same as sinusitis. The imaging features mostly premolar and molar teeth or root fragments mostly displaced into the sinus. It can be located anywhere in the sinus, but most commonly near the floor because of the gravity. And most commonly advised investigations for this is lateral maxillary occlusal view or Waters view help in localization. The imaging feature for this is the presence of radio-opaque mass with appearance similar to the tooth structure. The differential diagnosis will be anthroliths, shape of the radio opacity, and with the presence of pulp canal we can easily compare the difference. Coming to the management, removal of root fragments by Calvel loose operation. This radiograph reveals the portion of tooth root within the sinus, and we can also appreciate the region of hyperostosis from the floor of the maxillary sinus, which mimics the shape of the root tip. So these are all the pathologies which are associated with maxillary sinuses, the intrinsic one as well as the extrinsic one.